Okay.
With CD.
Yeah, let's see.
So I recuse CDBG process because of work. So, I mean, I will come listen to. So CDBG is going to be the first hearing, the software hearing.
First off, we had 15. And then, the 20th.
Welcome back.
The 20th is
Is that going to be software?
the 20th is city with the city department. Yes.
For the 15th or?
The 20th.
And 15th is?
Hardware, yeah. And then we have the 28th. August.
Okay, 15th.
If you want to jot this down also. Our first, we will be having a regular monthly meeting, so we will be in 4:50. We'll be joint meeting with CD. That would be a third meeting, and 5:20, May 20th. Yes. And May 20th. And May 20th, sorry.
And
20th.
So April 15th?
Yes.
Not yet.
No, and the second would be
There's
May,
one in April.
1 in April, too.
And then one, no, it's hardware, you said?
April, yes, is hardware.
You said May 20th and May 20th.
Yes.
And will those be joint as well? Or?
Yes, Johnson. I think on the
It's software?
yes. And the date is a deliberation.
For hardware. I will not be able to do 6:30 or 6?
6 in chambers.
At
I'll follow. I'll have
Okay,
the send
great.
of that first. Yeah, all 6. I have just the send it out. Okay. We'll go. Good evening. We now call this meeting to order. Board of Alder, New Haven notice. Health and Human Service Committee will meet in person on Thursday, March 6, 2020. In the Board of Alder's Chamber 165, second floor, New Haven, Connecticut. To act on the following. LN 2026-0034 from Brian Davis, pathway physician of Texas, submitting a request to conduct an informal workshop regarding the proposed community health improvement program. These items are all and available for public inspection in the office of Legislative Services, 65 Church Street, New Haven. For order, Honorable Captain Smith, Chair, assess these smart city. If you need any accessibility related accommodation, please contact 203-946-7651, 203-946-8582 TTY. In accordance with state COVID-19 policies, masks are optional. Public may send testimony to public testimony at newhavencity.gov. Board of Alders meeting can be viewed at Board of Alders YouTube channel. Welcome, everyone. I will now introduce my colleagues. Starting from
Kelly Smith, board member. Sarah, I work for you.
Camden Singh, Ward 5.
Mags in the town, Ward 16.
Director Bonds, welcome. Join us. It's a pleasure. And Mr. Davis, you may come up. We're delighted to have you here tonight to speak on the CHIP.
Very honored on the agenda tonight.
We scheduled this workshop just to hear from you.
Interesting, members of the committee, it's great to be here. It's my first time to New Haven, so in typical tourist fashion, I'm walking into one of your best pizza places and walked around the campus and just a wonderful experience. I have spent 25 years in local government, and this is one of the over 2,000 city halls, so I've done quite a bit at quite a bit of cities.
May I interrupt you? May I state your name and address for the record, please?
Brian Davis, 122 Tennyson Place, Kyle, Texas.
Thank you.
Sorry. So I worked with the National League of Cities for 17 years, overseeing one of their public-private partnership programs. In that time, I was always taken aback by public health right now in our country. There are so many people that need affordable access to a physician. It's just simply not there in most communities. So I have a friend in North Texas. He is a ER physician. He came to me about 6 years ago and said, "Hey, I have an idea." He has a heart and a passion for helping people that don't have the money to be in the doctor's office. And so he said, I started seeing patients that would come in my ER. They have a single mom, 2 kids with strep. They would give them a $5 amoxicillin prescription, and then billing would come in and charge them $1,500 a kid. And it's just not sustainable. So that mom is now in a situation where she's either in medical bankruptcy or she is gonna not pay, and then that goes towards the breakdown of what we're doing right now. Healthcare trends and rising costs in the marketplace that is coming. So he started giving his cell phone number to patients that could not really afford to be in the ER and using the ER as primary care. And so that turned into 500 patients that were texting this doctor when they would get sick. So it was a little inconvenience for them, but a huge benefit for the families. So that doctor he became the Rockwell County Health Authority, which is a large county just north of Dallas County, Texas. So the federal government caught on to what he was doing, and he did a congressional award, and then he was appointed to a seat for a federal HHS committee to address the issue of doctor shortages in our country. So that's my partner, my co-founder, Dr. Barrett. So with that, he said, "Brian, there's some ARPA funding in North Texas City, and I think we can do this program. I think we could give every citizen the ability to have a 10-digit number saved in their cell phone that they could text a doctor and get doctor access every day of the week." So we met, the city manager, the mayor, and the council thought it was a great idea. We had funding for 3 years. It became the most used city service in that city, more than library, more than parks, more than, and it really did, and it's documented by their emergency management coordinator. It reduced 911 transport, hospital transport by 44.7%. So it's all great until the grant funding ran out. So how do you keep paying for this? And the average cost is less than $10 a month for a household. It includes up to 10 people in a household, and they don't have to be permanent residents. Right now, in the state that I live in, you are required by executive orders of our governor to show proof of documentation of residency when you go to the doctor, when you go to the ER, when you go to the urgent care. So there's a huge demographic in Texas, Illinois, and I'm assuming in Connecticut that are just not going to the doctor right now because they're afraid to. So because what we set up classifies as concierge medicine, we don't have to ask what we don't. You don't have to tell us if you're a resident of the United States, a citizen or not. If you live in a home in a city, and the city is paying our program, you can use our service. So that then turned into, well, how do we fund it? How do we do the $9? And in Texas, she's laughing. In Texas, we put a fee on a water bill, $2, $3 for care flat. And if you have to have a medical helicopter Uber to a hospital, Uber out of the city, it could be. But if you have this water bill, you don't have to pay. And anyone can opt out of that. So one of the cities in Normal County said, you should use your service similar to how CareFlight is on water bills. We said, well, okay, let's put $9 on one. So we did, and what happened was 20% of the residents dropped out, 80% stayed in over a 5-year period, just almost 5 years in Texas. And so we started replicating it. And we did cities in South Carolina and we went away. So I was at the National League of Cities conference as a Duke. We go every year in Salt Lake City, and I was sitting by the fireplace in the hotel lobby, and I said, "Mind if I sit here?" And it was a bunch of elders from New Haven. They asked why I was there, and I told them. And before I left, I was on the phone with Dr. Sari at Yale Hospital, and we were talking about this program. So I said, "Well, I've never been to New Haven. I'd love to come up and talk to you about it." I had quite an adventure today getting in the laboratory, but I got here. And, I wanted to just give you, I always tell folks, I'm not like a salesman, but I'm so passionate about this program. I just see the benefits. The benefits are in the stories. And never had a city, we have 20 cities now that are participating. We never had a city drop this program that launched it, right? And so we've had plenty of cities that have thought about launching it and almost launched it and didn't. You will have people, if you put this on the water bill, you will have citizens that say, why is this on the water bill? I don't want it on the water bill. And the response is, well, we'll take it out. And we give you 90 days to try it for free, and we'll refund your money if you don't want it. So it is, participation is, it's an all-inclusive program, but you can decline participation. And we have mechanisms in place. So for example, city outside of Chicago has an outbound notification system. Do you guys have like a code red system that can launch calls to the community? They launched it all over the community over the weekend. Did it again the next week, sent emails and texts, and they had 30% of their population opt out. Not a person came to the council meeting and complained. It was, everything was quiet on the socials. And it was great. And so now people are using it. But what's happening is the enrollment is going back up because now people in the community are talking about it and how well it works. And so people that opted out have opted back in. I will tell you, I have really good insurance. I'm very lucky, and I work with a doctor, so I have that. We like to say, if you know someone who's a doctor, and I'm assuming living in New Haven, you probably do. That's who you're texting when you get sick. If I don't feel like going to the doctor, if I don't want to go, if I know what I have, I want to go. And I had this person to tell the story, but just 2 weeks ago, my wife wakes up. She's like, "Babe, I'm getting a urinary tract infection." Um, so she texted, and within 5 minutes, I mean, she is already has a prescription called in. So at 9 o'clock when the pharmacy opened, I went out and waited and drove through, got it. The doctor said, "We're going to do cash pay for this. The lowest cost is at Walmart. The highest is at, I mean, they have all the broad spectrum. But if you're going to use your insurance, then I'll just call it. So I said, just call it. See, it was like a commercial. My wife, it's tax season. She's in county. She had a meeting she had to be at. She didn't have time to go to the doctor and do a urine sample. So she's pulling out of the driveway. She can't wait any longer. And I'm pulling them. I was like, please, because I'm going to have to drive to her office if she leaves. And I handed the medicine. And by lunch, she's better. There's a shot clock that starts when y'all get sick. And if you can triage that, you're going to be better. So we created, and we really have created utility as an infrastructure. Healthcare is an infrastructure. We have opened a new door, because right now, whenever someone gets sick, it's tell a doc or go to the doc. We are not teledoc at all. Telemedicine has copays, it's claims, it's insurance. It takes a while to schedule a doctor, wait on one, and they're all different. Some of them you don't wait as long as others, but some you don't have a high copay. But most of them started We don't. So imagine your employees now, when they get sick, they're not filing a claim on your premium, they're just texting a doctor and the doctor can prescribe them medication. And when they can't, they don't, right? So we don't do any, like, any heavy narcotics, any controlled substances, we're not going to do that. But I'll give you another example. I had a council member of the city that uses this. She texted the service and said, I am having really tightness in my chest and thought I'm having trouble breathing. And but we said, go to the hospital, and it immediately sends a little red cross and says, go to the hospital, we're going to call an ambulance. So we notified 911. We went ahead and called the hospital medical city where she was going, and they were waiting for her. Her sister ended up taking her to the hospital. She had acid reflux. So she has insurance. They prescribed, I believe it was Omeprazole, and it was hundreds of dollars a month for her. And she said, it's not just not going to do it. And then she thought, I'm going to text TAP and see if they could buy it. So she texted the service, and she calls me, and she's in tears, and she's like, you guys found it for $6. For $6. Like, yeah. And so one of the cities that rolled it out, and I can share the video, 55 citizens in a span of 2 meetings came forward to talk about how they, and it was, it had albuterol that was $300 a month, you found it for 9, or I was just worried about the hole, and I don't like going to the doctor, I don't like going to the dermatologist, and I took a picture of it and sent it, and they said, you're fine, and I don't worry about it. There's a preventative medicine to this that is incredible. Like you just, and the last anecdote, the power of this program is in the stories, because you hear them, and you'll see if you guys roll it out, we leave a place for comments whenever someone uses it, you get a text back, and then we follow up. But this is, hey, how was the service? People are right knowledge of this. It's really special. So we are, the way we set it up is we're not a private company that says we want you to put our logo on your water bill and we're going to, charge all your citizens for this service, because that's not what we do. We are trying to create a long-term community health improvement for the city of New Haven. And that starts with low cost, instant access to a physician for everybody, whether you're a business here or a citizen. If grandma is visiting you for 2 months and living in your home, she is not covered under the program. If you have aging parents that live in other parts of the state, they can't do out of state. So if they're out of state and not living with you, but if they're with you and staying with you, we can. We're going to use Connecticut doctors. So we're going to, I would love to partner with Yale Hospital. When I spoke to one of the doctors, they said, so would you want us to do this pro bono? No, we pay. We pay for the doctors. And in most of our physicians, we have PAs, we have NPs, and we have doctors, right? We have MDs. And most who have been ER visits want to have a family, and it's really hard to get back in if you're an ER practitioner and you want to get back in and have kids. So they were literally staying home with their child while they're providing that service for us. So, and pay them really well. We don't it's not an hourly, we put them on an annual retainer, so they have that constant income coming in. It's a wonderful program. So the last thing I was going to share is my daughter, who comes to New York a lot, she's a musical theater girl. And she was auditioning for a college fellowship last year, Texas Tech. And I don't know if any of you know daughters, but you get these texts that say, Dad, what the heck's the point? And that could be anything from, I saw a dog that I wanted to adopt to, I just wrecked my car, which I had both of those, and she said, I can't stop coughing. She has a reactive airway, and she had this audition. They know she has this because once you text, they keep a medical record of you. And then they called in Bronfen, and I went and picked it up, and she was 20 minutes away. And so within 30 minutes, it was in her body, and within 30 more minutes, she auditioned. And she was offered a scholarship to Texas Tech. So that's my way to brag about my daughter. No, but it's a real story, and it doesn't matter if you have good insurance. That's great. Insurance doesn't do this. This is like a concierge spa level type list. You have, the last thing I'll say, I'm sure you have questions. We will take $1 at 9, and we match it back. So you collect the $9 under the bill times your 50,000 residents every month, send it to us, and we take $1 per household, we put it in escrow. So 50 grand a year, 50 grand a month, 600 grand a year, I'm estimating. And then that would go into your community health improvement program. So food insecurity, heated and cooled spaces for extreme weather days, mental health crisis hotline. So when you see in your packet, we modeled into your plan. I just took the initiatives that you had already done, and I tried to create a community health improvement around that. And just so mission of community resilience, you say it right here, you aim to foster resilient people, families, and community, enhancing community conditions that positively influence health. You advance collaborative strategies that improve access to resources and health treatment. You address the impact of trauma and promote health and healing. And then the New Haven Health Department's mission, it's like our mission. The New Haven Health Department is to enhance health and well-being of all New Haven residents, focusing on health and safety, food protection, immunizations, and chronic disease prevention. The vision is to create a New Haven where everyone has equitable access to a healthy life guided by values of integrity, innovation, collaboration, and diversity. And that's our mission. So I think it makes a lot of sense for us to support something. I don't know what it's going to end up looking like, but I would love to try to address any questions.
Thank you for your question.
Thank you for the presentation. You're a for-profit or a nonprofit?
We are for-profit.
Could you just talk about your business model a little bit? Like how big are you?
Yeah. So we are a company that's been in business about 5 years. But the company's older than that. We started doing the monoclonal antibodies during COVID. So we were the second largest distributor of monoclonal antibodies. We cover about 500,000 lives right now, so we're not huge. It's not hard for us to add doctors, so we just continue to add as we go into larger populations. And so our business model is we have a break-even point, and it's very expensive to get instant access to a physician. So although you were to go try to shop something like this, it would be a lot more than $9 to do. And so what we tried to create is a healthcare consortium. Just everybody chips in, everybody participates. This could be the price. And then with that $50,000 a month, we could give back. That would go into an escrow. We would be able to use that for whatever you wanted. You could use it for the healthcare hotline, or you could use it for
Jimmy.
What was your profit last year? Just wondering the scale of the business.
I can get it back to you, but I don't know.
That would be great.
Yeah.
And could you talk a little about the choice to put it on the water bill or any kind of public utility bill? This is just selling it like a regular subscription service that anybody would be able to opt into.
Right. If you do it that way, you get less than 1% of people typically take that. And so we cannot do we can't put a dent in the problem if we go door to door that way. I mean, and one of the reasons before I did this, I worked with the National League of Cities on their service line, where they help cities restore the residential water and sewer line of all their constituents. And we ended up growing that to be, well, it sold to Brookfield for 4.1 billion. And I was in the very startup phase of the first company that did that. And everyone said, never do this. Cities won't get involved in the sewer, warranty. But we did, and we became the largest private sector infrastructure repair company in the world doing it. So a city pushing this out and going through the city, all this unusual, very powerful for the community.
Thank you. Any other questions?
Brian?
Yes, ma'am.
Oh, okay. I love this idea.
Thank you.
I like the water bill or any bill part of it because to me, it's just like any bill. Like for instance, my UI bill, I pay $3 extra because that helps people for heating for their homes and everything else. That's less fortunate to get because I pay that extra. I like that more than if you present it as a service, it's too much of a responsibility to keep up with people. They pay it, they don't pay it, they pay this one, they don't pay this one. The other thing is, this has to be the answer. Because waiting in the emergency room for 10 hours for Eric, for them to just say, rocks, it's gotta be a better way. How many, and thus far?
Right at about 20 cities. We're currently meeting with council, different city councils for we're on about 4 agendas. I mean, yesterday I talked to aldermanic board members from Chicago and Milwaukee. So we're getting some big cities that are really looking at this. This would be our biggest city because the big cities have, once you do this, we just need one big city. And I'm calling you a big city. And this is going to be like center stage for the Cities Conference with talking about how government shut down over the rising cost of healthcare. A city fix this at a municipal level. And I believe that's the case because you will not find, and you'll have your fair share of naysayers, right? But no one who naysays this has ever used it, ever. We will have 25 people line up to say, thank you, look what it did, look at how it helped me. We'll have 5 people say, this is a scam. Or I can't use it. Right? Like, this is something that really changed the game. And I will tell you, one of my children had a fingernail that got infected. I texted the doctor, they call in Keflex. But staff could happen, so I want you to take her to the urgent care just to be safe. So we get to urgent care, they look at it, $204 later, guess what they did? They prescribed me Keflex. I said, I already have that. And I'm not kidding. She goes, how'd you get it? And I said, well, I texted her. She goes, tell me more about it. So, I mean, but that's, and like I said, 5% of people go to a doctor.
But as a woman or anybody, a certain age, you kind of know your body. You kind of know, when you get symptoms, like how your wife, we know.
Yeah.
So
Yeah.
who wants to sit in an emergency room for 2 weeks for an appointment? I don't know what is going on these days with these appointments. I've been waiting 3 weeks for those appointments. Like,
Well, we also, because of the prescription drug discount we have, a lot of it is just people don't know to ask for manufacturer coupons too. Now we use Mark Cuban's Cost Plus drugs. We also use the coupon, manufacturer coupon. But we've had people, the doctor wants me to get an MRI because I have a leg, and they can't get me in. The imaging clinic can't get me in until next Friday. Well, this one situation, it was $1,200 is what she would pay for copay, and they couldn't get her in for 5 days. Well, if I have a ring in my ear, my doctor says you need to go get an MRI. So she texted us, "Can you get me it quicker?" We did. It cost her $500. We can do lab work, request, full blood work with full labs for $30. So it's we found the right ways to shortcut the expensive, and we're able to provide that to our folks.
Alder Smith?
Thank you, Chair Singh. Thank you, Ms. Davis.
Yes.
For the presentation. I just have a few clarifying questions to better understand your business model. So you said, what's the average population that this cities that here?
12,000 people.
12,000.
Yeah. Largest is.
Are you working with Garland?
Not anymore.
Yeah, Garland's like 245.
Yeah.
Yeah, what happened?
Garland signed a contract. There was a group of, there's a group of 10 people. Yeah. I guess one of them reached out to you.
No, I just saw it on your
Oh, yeah.
the email just there.
Yeah, so,
that you're
yeah, we have a person that literally will go to every council meeting that I go to. This is a scam.
No one did that. So I just noticed the video was the Garland. So I just said you said that this.
It was
It's like
Garland.
actually pretty big.
Garland
So
was.
they're-
What killed it is they couldn't put it on the roll for 9 hours. It was doing a new utility bill, and that gave this contingency of 10 people a really good meeting. And so at the end of the day, we subsidized almost $1 million of free healthcare because we gave them everybody to use the system during cold and flu season. And of 250,000 people, we had 6,000 households that opted out. And we had 1,000 people enrolled, and we had almost 3,000 uses of the system. So like it was working, but it happens. It's not the first, won't be the last, but that hurt.
So the average population.
Mhm.
And what's the average percent? Is it average?
It typically will start at 70, and then it goes back up to like 8 because people will start hearing about it. And they're like, "Hey, I opted out of that," and they use it. So somewhere 75% is the good rule.
And I think you use $9. What's the average charge that are $9?
Yeah, 9 is our standard now, and to get our first big city,
Yeah.
we would negotiate because we want to have the first big one to try. And when you ask about what our revenue was like, well, it's hard because one year we got a bunch of, right? And then, so that's really not reflective of what our revenue is, but I'm going to to get that. I forgot your actual.
Just the average charge on a water bill, for example.
So we like to make it 9 and then we give the dollar back.
Okay.
So we call them match back. So it's not your dollar we're giving back.
Okay.
It's just our dollar. We're matching the dollar for your assistance or for your community.
Right. And then what's the average just FTE staff for an individual city the doctors are supporting?
So how many per population? Yeah. That's an interesting question. Because it's way less than you probably think. We would say, so let me walk you through this. I can show you on my phone. Like you just go to a 10-digit number. So I go to my contacts and I hit tab. And so then my card comes up. So I hit the text and I'm a hypochondriac, so you're going to see all all my uses. Oh wait. So when the nurse comes on, this is the TA that comes on at first, and this is when my daughter had the nail thing and she was getting splotches on her leg. So I started the conversation. Okay, here we go. Hey, she's got a puppy nail. Here's the situation. She's taking care of 23 years of experience, and then she sends her contact card so I know who I'm talking to. And then, but to get to that, it's just like a digital scribe. So I say, hey, I need help. This is what's wrong with you today. While it's getting facts from me, the symptoms, it's picking the next doctor. So we say we never wait more than 2 minutes for a doctor. So it's quick, but to answer your question about how many. So in Garland, we had a population, when we were building it up, we had brought on board 10 new doctors total to handle 200,000.
How about in one of the cities that's currently still working with that small, like one FTE, two?
I would say like for 50,000 people, we would need, for 12,000 people, one, right?
Or I guess what, for one of the cities that you're working with now, how?
So Algonquin, Illinois, we have three. They have 33,000 people. So those are Illinois licensed doctors.
Okay.
And then the first year, I'm not going to see usage as much. People are still used to calling the doctor, like, if I have something, I have to, and it's like we opened up a different door, and so it's the partnership. That's why we want to be your program. It needs to be a new Haven Health or whatever you want to call it, right? And we will work with you to do things, to do like the trifold signs in front of high traffic areas, QR code. We'll do inserts in the bill, we'll do all sorts of things to get the word out to everybody, right? But and then the all call and the all FedEx and the all email. But to participation wise, typically the first year might be 25%. The first year is not going to be high unless you really help us push it.
Right.
Now, in some cities, it's 50%. But the very first year, and also depends if we launch it during cold flu season or if we launch it in summer.
Right. Totally.
But I would say our first state who's now been in going on 5 years, they have at times about 70% that use it in a year, which is incredible. When you think of telemedicine is usually about a 1% use rate. Like I have telemedicine, but I don't know how to get in the app. Like I haven't used it in years. Like I haven't. But
And so there's 3 FTEs. Are they fully paid for months, or is it percentage of the time and the rest of the percentage?
we pay them based on usually around $175, $150 an hour, 40 hour work week for a year.
And let's just say full throttle, so that one city that's operating 70%, about how many tickets or how many work orders in a given day for the doctors?
So we launched Algonquin in November. Again, they had about 30% after. Also, we narrow that down to households, 80,000 households, which represent, let's say, in the first 2 months, we had right about 500 interactions. So,
in a month?
And that for the first 60 days.
For the first 60 days, 500. What about further? And I'm just trying to understand that. I'm just trying to understand how are you paying for doctors and given the number, given the amount of revenue, and just trying to.
It's all an actuarial model.
Yeah.
Right? So they have there's a model based on how many lives we're covering versus how many doctors we need. Make sure you're always at that, because if we're covering lives, we're getting revenue to pay those providers to cover those lives. And then in Connecticut, because we don't have a doctor in Connecticut yet, because we don't have a Connecticut city, what we would do, you said, launch it for staff and just do a pilot for a month. We would license one of our doctors that's already in another state in Connecticut so that they could see the pilot. Or we could get our somebody at Yale Hospital, however you want us to. So it's very customizable. But then once we start getting like, if you were to come on as a partner, we would immediately start behavior doctors.
And just one last question, then kind of overall. Just going back to the kind of number of tickets or texts. So, taking that city that you've been with for 5 years, when they've been operating at 70%, with around 3 FT,
Mm-hmm.
about how many texts per day? Do you have a sense of just what's the
I don't per day. What I do get daily is our top 10, like most frequent illness. Let's see, but
per month?
it's so that city had 2,000 people. We would get, and by year 5, 70% are using it a year. I'm not sure we have that metric. I can look for it, but the reality is people use this. Well, when I say 95% of our texts don't go to a doctor, I'm not saying that we're taking 95% of your doctor's business. I'm saying that way more people are getting a doctor to look at their issue.
Yeah.
So it's like, I wouldn't go to the doctor for this because I'm angry, or I'm worried about what they might say, or another city told us that after the first 2 years, they had 12 suicides 2 years going into our program, and after they had 0. Now, I have an idea of why that happens, is because, and I'm not an expert, but I actually think that oftentimes that word is a knee-jerk response, right? It happens without that person thinking, and we're a lifeline that they know if they text. So medical professionals got to text them back. They don't have to look at them. They don't have to angry, and then we can direct them to a mental health facility that is in that.
Makes sense. I think so. This is my last question, Mr. Chair. Thank you. I think I'm just trying to wrap my head around the economics. So you take a 12,000 person city and average 75% usage, $8. That's about $72,000 in just the revenue alone, not including insurance, etc. You take a doctor, 3 FTE that are paying an hour for 14 hour days.
For city, that would just be
one FTE for 14 hour days, 175. For let's just say 325 days a year, that's over $700,000 salary. And so I'm just trying to square how the economics works given the revenue coming in and given the expense of the doctors. I'm just trying to get my head around.
So that doctor that we got assigned for that is never completely inundated. So that doctor is always available if another city needs it. So you're never going to have this logjam where everyone's using it at once. It's spread out, so it's load balanced. So we have Texas physicians. They can take any call anytime. And if someone's busy in that city, it'll roll to another.
Thank you, Mr. Chair.
Thank you, Paul. Any other questions?
I'm just curious as to, so it's through text. Once they reach a physician or a doctor, does that change over to something else, or are we still communicating through text?
Great.
This,
If they want to, we can. So if they want to talk, if they want to FaceTime, we can do that. Given that option, I believe it's 97 or 98 still prefer to stay in text.
so how do you know that you're addressing the right issue with the medical problem that the person is experiencing? So is there some sort of follow-up in a way that this seems a little more concrete as far as the care?
Right.
Residents.
So you'd be surprised, in most hospitals, if I go into an emergency room, they don't really have my medical history, right? So that ER doctor on staff, they're having to look at what I'm telling them and make a decision based on. So we will always say there's nothing better. The gold standard is to be in a doctor's office is having them look at you physically, but know that not everybody can do that. And so this is, not to mention there's a time tax. We just don't have time, and we don't have the ability to take time off or do something that could be triaged by the text-to-doc service. So do pictures, we can do video, we can do phone calls, we can do text. We follow up within 24, 48 hours to make sure they're doing okay. And in 5 years of doing this, we've never been accused of misdiagnosis or anything like that. So again, we're not huge. We're not huge. We're starting a movement.
That was my next question. If,
Majority Leader joined us. Thank you for joining us, Majority Leader.
The next question was, has there been any cases in which they give care for medications or something that really they're not being for whatever issue is happening, and so has there ever been a case in which there has been an issue in what they were given?
No. And our doctors are responsible for the care that they give to their patients through our service because they're the ones that would get a medical malpractice suit, right? So they're not going to do something that we put them at risk. They hold coverage out that they're hold. We haven't had that.
What does that mean, full coverage amount?
So each state requires a mandatory amount of medical practice coverage that you must have. So all of our physicians have that. So we're a physician network group is what we are. So we have a large group of doctors, and each one has to have their own.
So how would you do with a patient that had chronic disease?
Another great one. So we had this recently, and this says so much about our service. A 3-year-old girl got strep throat. Mom texted us. See the picture. People will say, don't you need a lab test for strep throat? Right? Well, a huge percentage of people are chronic carriers of strep throat. They just always have strep throat. They will test positive all the time. My son is one of them. So you can ask certain questions, you can look at pictures, you can see the pus pop over, all the things that you can say, yeah, this is strep throat. So she had it. We called in the prescription for her. 3 weeks later, she got it again. So we said, okay, we're going to do it. And then we're going to follow up, and then we're going to send you to an ENT. Well, she got it a 3rd time. So we sent them to the ENT. She needed her tonsils out. So they took her tonsils out. Now, in post-op, we get a text from this mom that says, hey, we got the tonsils out and she's got a lot of pain and she's bleeding. What should we do? And we said, well, when did she get released from the hospital? And they said, we're in post-op, we're still here. They're texting us about their daughter that just had strep throat in the hospital, and they're in the hospital, and they're like, well, we knew we could get you faster than waiting for the doctor to come in here to see us. So, the doctor came in and did all the things, but like, we're not in there. Like with my daughter, they sent her for care, they sent her to the urgent care, that they did with the rest of the strep, her strep with the staph infection or so.
Is there a maximum amount in which you're allowed per person as far as expenditures would go in care that would basically be received outside of your doctors?
No, so you pay $9 a month. If you have 10 people in your home, you never pay $1 more. 10 people use our service as often as they want from 7 a.m. to 2 p.m. And if we refer you to someone else, such as the clinic and all that, we can negotiate a low rate for you, just like with medicine. It would be up to the patient to pay them. But our average prescription drug cost is $12. So we're able to get that
So they would have to pay if they were to have to go to the ER, but if they have to get outside of this service that you provide.
We would not, if it's past the point of acute, we're going to send them to the ER, right? And we did, we've had a million children, but we did have a lady that called and she said, I can't breathe. We told her, we told her she couldn't breathe, and uh, we took her, called her an ambulance, transported her, and they intubated her immediately. She was having lung failure, and she's 51 years old, had COVID, had respiratory illnesses connected to it, and she's one of the ones that came forward in Garland and said, "This company saved my life. Like I would not have. I just thought I had a cold, you know."
When you say that you got her an ambulance, is it covered under the service that you provide?
So we called 911. I'm sorry, we called 911 for her city, and they dispatched an ambulance. But we do call the hospital ahead if we know the ambulance is coming, and we're like, hey, this is the patient, this is their name, here's their information, we get them in quickly. A lot of times they can.
So your service really provides for most of those sort of set of problems or medical issues that people would have in general.
It's just not what goes
Basic.
acute, the itises, the strep, the flu, the pink eye, I've split my ankle, I need to go to the hospital.
UTIs, that sort of.
UTI is number one treated illness outside of cold and flu.
Thank you.
Yes.
Oh, okay. Two more things. Okay, I can see why, and I feel like that's a benefit with the water bill thing, for instance,
Mhm.
because that makes it per household versus per person.
Yep.
And then the other thing is, I work in here, so I understand that it's more common than not in 2026, sure. When people come to facilities now, and if you even just call and say, oh, you know, I got a fever, such and such in my throat, don't come in. Well, you don't come in
Don't
no
come
more.
in.
Stay home
Mhm.
and take such and such. So it is actually the newest technology way from a crowded ER, people full of cold flu and everything else. And when I went to the emergency room 2 weeks ago, a few months ago, and so I was a little bit dizzy.
Mm.
So I go in there and I work there, so you know I know the people at the desk and everything. So she's going, "What's wrong with you?" And I said, "Oh, I'm feeling dizzy." And she was like, "You sure?" And I said, "Yes, I know I'm feeling dizzy. I want to be seen." She said, "Okay, because if I press this button, that's $300."
That's it.
I said, "Wait." I said, "Just wait. Let me just walk it off." Sure enough, I just sat there for about 20 minutes and I felt fine. Now imagine me getting a $300 bill
Yeah.
because she hit that button. I said, "Wait." And what is costing people? Oof.
And it's not just, I mean, that is a great example, but it's also, you talk to the fire chief or EMT. They are by nature adrenaline junkies, and they want to go save lives. And they will tell you that in today's day and age, 96% of their calls are taking somebody's blood pressure and transporting people to the hospital that need to see a doctor for primary care. And they're getting burned out. I mean, you work in the ER,
I was gonna.
people are getting burned out.
Oh my God, no idea.
It was, the local hospitals love our program because we clear up their ER.
Mhm.
And maybe the really expensive clinics that the quasi-governments are super huge fans, but we tell them the fields give everybody access to your clinic for $9 a month, we'll go home. So this is it's a new door. But yeah, they're burned out.
Director Barnes, like to come up, please? Any questions? Thank you for coming out tonight.
Where should I sit? That's right.
Right.
Good evening.
Name and address, please.
Marissa Bond, resident in New Haven, 424 John Street.
Like to participate?
Sure. I don't have any direct questions, but I do want to provide some feedback, for sure. So as you know, the New Haven Health Department is committed to expanding access and addressing disability. In every neighborhood in the city, we welcome innovation and we also welcome partnership. What we ask in this specific initiative or any initiative is that when we're talking about the community and the residents is really looking at ways that we are meaningful and inclusive and also uh, utilizing the plans accordingly. So I'll talk a little bit about New Haven and his current access to healthcare as a whole. So as you know, New Haven has a meaningful and growing access to infrastructure that exists. Many of you work with these different partners, and that includes telehealth services, which I'm particularly because I'm a busy health director and don't have time to go into. And partner with Yale New Haven Hospital, actually, who offers telehealth services to providers across many specialties that are bookable directly through my chart or even through a regular website portal. Likewise, the Cornell Scott Health Center is Connecticut's first federally funded community health center, who in partnership to have that foundation many years ago and offers telehealth services for most of their visits that include behavioral health services, as well as medical specialties that are either by phone, tablet, or computer. And they have a slight fee for uninsured individuals, and they offer services in multiple languages. Likewise, Fairhaven Community Health Center, which we serve on the board, continues to expand their services and also service over 160,000 visits annually across 21 locations across school-based health centers throughout the entire city. The health department, we also operate a health and wellness center directly, and some of you just attended the meeting we held. And want to thank those alters that were able to participate and get a tour and learn about our services. Some of you were able to make it, and so we can host you in the near future. We offer and provide school physicals and routine childhood vaccination so that individuals can have access to school and be able to start school on time, and we can contribute towards reducing the truancy in the district. We offer STI services that are confidential. We also treat tuberculosis testing and vaccinations that include respiratory illnesses for COVID-19, flu, and otherwise. We also are available for providing services that are either low cost, or we will provide free services for anyone that does not have insurance. So we will not turn anyone away. These services are already embedded into the neighborhoods where most disenfranchised communities live. As you know, we do a lot of community initiatives. We, during the fall and winter, are always at community location offering vaccinations and services online, and so do our partners that I've just listed. Our purpose is not to dismiss what has been presented this evening, because the committee deserves an accurate picture of what already exists before considering anything new. Likewise, the New Haven Health Department is generally committed to expanding access and addressing health equity. As you know, we just launched our 2026-2030 strategic plan that was developed with input from residents and community partners citywide. We have also supported the Greater New Haven Community Health Needs Assessment for many years with the Healthier Community Partnership, who are the winners of that report. And that's their partnership with Data Haven, which I sit on their board. Our own community health assessment, community health improvement plan, are currently in development and in its final stages and are getting ready to be released, which we will be hosting publicly, and those all entails. That planning work matters here because any new community health program, particularly one that will involve a fee assessed to city residents or a contract with an outside vendor, we need to move through a deliberate process. Community needs assessment alignment with identified priorities and the city's procurement committee for review. That is a true for any proposal that we handle as a city, regardless of how hard it may appear. And the health department looks forward to being part of that conversation as it develops, and I'm happy to answer any questions that you may have.
Director Barnes, thank you for what you did at the health department. Comments, any comments or questions?
Director Bond, I mean, being able to pick up and call a doctor or text a doctor sounds very nice. My assumption is that the reason that this does not exist already is because it's cost prohibitive at scale. Do you have any sense of whether how true that is or isn't?
Oh, I just noted how several different organizations, different providers are already offering some level of scale within their current infrastructure of face-to-face. The cost of it is, I don't have those facts. It is I mentioned you in the hospital, I worked at the hospital. And that's more on education, because we know that certain people rely on emergency rooms because they don't have insurance, they're not aware of the resources available. So that's like more of an education component for me, where residents really need to, if we've been working from hard, the local providers, the education piece of like what's available and how do you avoid for things that can be consulted either through telehealth or face-to-face. Many families, especially families that we work with, they have two jobs. They're navigating multiple things. And so that skill in some level of that infrastructure is already in place, especially when you're referencing Yale.
But on demand is different, right? You have to get something immediately on your phone. That is a service, and I think even though some people don't have, but I mean, Carlos Smith brought up some of the economics. It is difficult for me to imagine that is really cost to have an on-demand service for the whole city of New Haven is really viable financially. And that's why we think this already.
I'm sure. And it's also, since we kept referencing the community health needs assessment, it's also, that's a technical issue. And when we're looking at community health needs assessment, out of that, there's structural issues that are happening, there's social drivers that are impacting the residents. That access to care was not only, it was more around discrimination that we need that we are trying to work with around the equity piece of access to health. And so that's something that we have to think about.
Thank you.
Thank you, Director Bond. Alder Smith.
Thank you, Chair Singh. Thank you very much, Director Bond. Maybe a somewhat similar question to Alder Miller. My familiarity with the landscape is that this kind of concierge service exists for highly affluent patients who have the ability to have immediate access through high degrees of payment. Is that your understanding as well when you have a sense of the sort of market of these kinds of more private services, that it's really the higher end of the market for individuals who can pay that kind of concierge?
Right, and when we're dealing with individuals that are disenfranchised, affordability is something, right? And then also, if you're having an on-demand system and you have to still go to the emergency room or you still are not resolving that issue, then we have to go back to square one, and they have to be referred to, they're going to be back to, we just had an alter admit that she had to say, no, never mind, let's take a walk. But probably $300 to get an intake. And so it goes back to the affordability. And so we can talk about access here when we're not looking at the other structural factors that are.
Thank you, Director. Thank you, Tracy.
Any other questions? Thank you. It's a great model. We appreciate you coming out here and
Yeah, all the way from Texas.
all the
Yeah.
way.
And you guys had this tonight.
It is presentation to us, and it's a great model, and it did not fit everyone. Here is a model that it was for. I think you brought it up. In New Haven, it got a little bit structured because of a multi-units. Most of our property here, I don't know what percent of it offhand, but they're multi-units. So a model like that, I don't know what the structure will go into that.
We would provide it to, if there's one bill, 1 meter, and it gets divided amongst the tenants, we would do it for $9 for the
For
entire building.
instance, for the entire building, let's say 15 people.
We do that because mostly in most states, the multi-family master meter are the lowest income. Want to make sure they have access to it.
That's a good thought.
And I'll also say that on the, I mean, I'll send both of you financial information you want, but we have raised quite a bit of professional money that has seen the model and knows that the model has invested a lot of money in us. So I can tell you that the model will work.
I talked about a model, for the entire property to cover around 15 occupants. I think for $9 it's good.
To cover 15 units or 50 units or 100 units for $9.
It's great. But yeah, like I said, for everyone, we just to have that access. But thank you for this presentation.
Yes.
We'll definitely follow this forward. See what comes on.
Well, I really appreciate your time and hope I can come back again.
Thank you, Steve.
Thank you. Have a great, have a great rest of your meeting. I am the meeting actually.
Thank you.
Have a good night.
Thank you. Seeing none, do I hear a motion? So what's
Second.
That's a
Public portion? Like to,
Is there anyone in the public need to testify? Anyone in the public need to? Anyone in the public need to testify? Seeing none, do I hear a motion to move down?
close public portion.
Thank you, second.
Second.
Okay, so is there a motion to move that? I hear a second.
Second.
Okay, all in favor for reading file? Say aye.
Aye.
Ayes have it, motion to adjourn.
So moved.
Thank you.
Favor?
All in favor?
Aye.
Aye. Yeah, ayes have it, so motion to adjourn. We are not adjourned.
This is the most formal meeting I've ever been to.